Hey, as an EMS CQI leader, did you ever, after reading a run report, just put your head in your hands, shake your head, look up to the sky sobbingly, and ask why? If so, you're going to love this show. Hello, everyone. I am Kevin Kelly. He's the Sultan of EMS CQI, Paul Gerard. We are Gerard and Associates, your national EMS CQI consulting firm. Check us out at www.gerardassociates.com, where you'll find Paul's latest article, Understanding the Why. You're listening to the G&A Way EMS CQI podcast, available on Podbean, Apple Podcasts, YouTube, Spotify, and everywhere you get your uplifting EMS CQI news. Please hit those subscribe buttons. Leave comments, please. We're grateful that you've tuned in today. Hey, Paul, how you doing?
I'm well, Kevin. I'm well. How are you?
I'm doing great myself. Great topic. And, I know that, I may be hyperbolic at times, but I got to say, I think this is probably one of the most important subjects that we've done thus far.
Yeah.
I mean, and it's not just EMS, it's just the broad spectrum of everything from the 1986 Challenger shuttle disaster to the January 15th, 2009 Sully Sullenberger landing a U.S. Airways jet on the Hudson River, to the February 27, 2009 alleged paramedic-induced ketamine death of Elijah McClain in Aurora, Colorado, to the February 17, 2020 just happened Delta Airlines jet landing upside down on a Toronto runway. And that fundamental question, and the only way you get to the root cause in almost all of these cases, regardless of the industry, is the ability to answer the question why. And it couldn't be a more timely topic, Paul.
Yeah, certainly in EMS has been all sorts of strangeness going on that makes you scratch your head and ask the question why. But integrating why into your everyday CQI practice, your day-to-day practice is what we're talking about today. And it's something that most CQI officers don't do enough of. They don't dig deep enough.
All right, so let's get into it. Let's start off. Let's talk about the traditional CQI programs that are out there and the limits of those traditional CQI programs are of. What is the traditional CQI program, Paul, in your view?
Well, the traditional program, and at least in EMS, it's fairly widespread, is most people are busy looking for the what, right? So they're busy looking for what went wrong on that call, what happened that was less than desirable, so that they can then go about fixing it. So they go from the what to the fix, and they skip the why.
And what's the problem with that? I mean, why is that a limitation? You've identified a problem, you've fixed the problem, life goes on, does it not?
Yeah, well, sometimes it does, sometimes it doesn't. So you want life to go on, but it may not if you don't ask the right questions. And it's similar to, from a patient care standpoint, going up to the patient and saying, what's your problem? Oh, I've got some acid reflux. It's just from my normal acid reflux. And so the provider doesn't go on to try to determine whether this is cardiac in nature or there's some other cause for that burning in the middle of his chest thing. Just because the patient gives them the quickie answer doesn't mean it's the right answer. And CQI officers do that all the time. So they read a run report and they say, hey, the provider should have ALS this patient. They go meet with the provider and they say, how come you didn't ALS this patient? The provider gives them a stock answer, usually because they want to get out of the CQI process with as little pain as possible. So they'll either just out of the gate say, oh, yeah, I understand. Next time I'll ALS that patient. Or they'll give some sort of cursory explanation, usually trying to defend their actions from a clinical standard point of view. So I didn't because I didn't think it was cardiac in nature, that type of thing. And so up until that point, you're going down a certain pathway, and here's where you come to a fork in the road. You can either continue down that pathway of discussion, or you can start to guide the question into, okay, but why did you make the decision that you made? And the reason that this is important, Kevin, is because this will dictate how you should fix the problem at hand and whether you're accurately diagnosing the problem at hand, the reason that the provider did what they did. If you don't get to that level, then you're really providing a fix or a cure when you're not really sure what the diagnosis is yet.
So based on the GNA data, your one-on-one interviews, why do you think so many agencies stay stuck in that surface level CQI analysis?
Yeah, again, there's a bunch of reasons for that. Probably the more common reason is that most CQI officers have not been trained in doing proper CQI. So the logical conclusion, if you haven't had any formal training, is to read the run report, discover what went wrong, and then go tell the provider not to do that, do something different. So I think that some of it is lack of knowledge on the part of the CQI officer. But another big reason is expediency. We've talked about this over and over again, Kevin, on our podcast, that most, if not all, EMS agencies underfund their CQI efforts. Yep. And what that does is it results in one person reviewing 10,000 calls a year, and they don't have time to delve into the details of any one call unless it's a tragic call, unless it's something really, really bad.
Right.
But for the day-to-day CQI follow-up, they're just trying to process as fast as they can to get these calls off their plate so they can move on to the next call because they're overwhelmed. So those are the two biggest reasons, is maybe a lack of understanding as to the approach they should be taking and the lack of time resource that they have in order to get the job done. There are other causes as well, but those are the two chief issues.
Now, how big of a role do you think leadership from the top affects the ability of the EMS CQI pro to do their job?
Almost completely. I mean, if you're underfunding the CQI process, you're shortchanging the ability for that CQI process to work properly. And even more of a sin is if you don't provide the CQI officer with the support they need to get the job done in terms of validating that CQI is going to be an important part of the culture of the organization. So, senior management sets the tone for all of this, and whether your efforts are going to be successful are in large part due to both your medical director and your senior management making sure they're setting the right tone. And that means giving the CQI team or officer the resources they need to do to get the job done properly, which would allow you to get more in-depth into some of these calls to determine the real cause, the root cause of the problem, so that you can determine the proper fix for that problem.
Yeah, we've said in the past that your agency budget is a value statement. And if you look at the expenditure on EMS CQI, it doesn't take a rocket scientist to figure out how much they value actually finding out the why.
Yeah.
And from my view, talking to these folks on my end, in some of the issues that I've interacted with EMS providers over, the time constraints, it's the budget, but there's this overwhelming sense of fear of retaliation, all kinds of things from the top down that leadership has got to get a better handle on.
Right. And that filters through.
Yeah. So, having done hundreds of thousands of these one-on-ones across multiple states, what's the consequence of never asking the question, why? What's the consequence to the patient? What's the consequence to the provider?
Yeah. Well, again, you're not getting to the root cause of what caused the problem to happen. So if you can't get to what really happened, then you can't fix it properly. And if you can't fix it properly, you're going to have problems again. So, if your car's running rough and you've got a clogged fuel filter, but instead you diagnose some other problem and put money, time, and effort into fixing that other problem, your car's still going to have a problem. You're just not fixing the real problem. So you're leaving your providers out there to kind of hang and dry if a problem occurs, if you didn't get to the real root cause and try to fix that so that the problem doesn't occur again. And so the problem routinely does occur again, not just with that provider, but with other providers as well. And so all of your efforts really are for nothing because you're not really fixing problems. That's the point of CQI, right? Is to fix issues so that they don't recur.
Presumably, yes.
Presumably.
But unfortunately, there's a ever-increasing concentric circle of stimulus and distractions that apparently get in the way of that. Mm-hmm. And, it's why in my view anyway, the traditional CQI program, the finding out the what or the how, and not getting to the root cause is really the big problem. So let's get into it. The power of
Yeah.
asking why. Let's get to the good stuff. What does asking why actually reveal in your CQI reviews? Put it in context. What are some of the things that you hear that are impacting a provider's ability to follow a statewide treatment protocol?
Yeah. Well, they break into, in my mind, and my mind doesn't always work the way everybody else's mind works, but in my mind, it breaks down into two categories: your clinical related topics and your non-clinical related topics. And you could even say your job related topics versus your non-job related topics. So the reason for the why for providers' errors can range amongst a ton of different potential scenarios. But the more common ones result into something that you can fix, which is lack of knowledge on the provider's part, whether it's knowledge of protocol, patient experience, right? I've never done that before, type of stuff. And those all go back to some degree, your EMS background in terms of training, orientation, and whatnot. And those fixes, if you don't go to the why, again, you're kind of blaming it on the provider and stopping there, as opposed to digging deeper and determining that the issue is one of the orientation process, for example, doesn't provide the education that's needed. The training institution doesn't provide the training institution, and so this provider has a problem, but it's not a problem that you're really fixing if you're just blaming the provider for the problem that occurred. So those are your work related, your EMS related. But I have to say, in this day and age, Kevin, I'm seeing more and more that people are bringing their personal lives into the workplace much more than it happened previously. And it's because of stress and strain on providers, the lack of employees, getting suitable employees. So we're overworking the employees that we have. And there's all sorts of personal stressors. And I can't tell you how often when I meet with providers where the discussion starts around, hey, Bob, how come you didn't ALS that patient yesterday? And at first they try to give me clinical stuff. Well, he wasn't serious enough to warrant ALS. And, we get into that. And then once we kind of get over those and prove them out through discussion that, that probably doesn't hold any weight. A lot of times when we dig deeper and I talk to them and say, Bob, this is unlike you. You're usually right on top of this thing. This is kind of unusual for you. What's really going on? If they trust you enough, Kevin, if you've got a good working relationship between your CQI officer and your provider, that's when providers will start to open up and tell you all sorts of things. I had a fight with my spouse before I came into work that morning. My wife notified me yesterday that we're getting a divorce. And while we're not supposed to bring that stuff to the job, it can't help but impact you. If you're distracted by anything else, financial issues, emotional issues. We have providers who are bipolar. We have providers who have drug abuse, substance abuse problems. We have providers who have mental health issues. We have providers who have all sorts of, my dog died. There's all sorts of things that can distract you to just take enough of the edge off of your performance that something happens that shouldn't have happened. And getting them back on the beam is critical, and you can't do that unless you understand what they're really going through and what's really bothering them. Not that you can solve some of their personal issues, but at least if they know that you understand the circumstances that they're working in, sometimes that takes some pressure off them. So giving them a chance to speak and talk about what's going on is critical, and they won't do that if they're not comfortable talking with you.
Yeah, I couldn't agree more. I represent quite a number of first responders who are in either have family issues, child custody issues, but unfortunately, mainly jump into the criminal defense system. And frankly, the amount of fatigue, and that's a place where we really try to understand why. Before you go on before a judge and you're facing incarceration or you're facing termination of parental rights or something like that. But the amount of fatigue, the amount of PTSD, the amount of anxiety,
right,
anxiousness, depression, and I'm not a psychologist. I'm just a empathetic, compassionate criminal defense attorney and podcast.
Is that an
co-host.
oxymoron? Isn't that an oxymoron? Empathetic defense?
I I thought we I thought we agreed that we weren't going to use the word moron uh, anymore on the show.
Right.
But
Oxymoron.
yeah, right. All right. Yeah, but yeah, I mean, but yeah, I mean, staffing shortages, burnout, um, leadership issues, the winky wink, nod nod, the workplace injustice,
Yep. Internal
the
politics.
yep, the biasness that folks bring to the table. That is that's a weight that is dragging down the ability of an EMS provider to become a one percenter.
Hmm.
Now, is that our problem? It used to be. It used to be that. I mean, it didn't used to be our problem. I agree with you. It was seeing a dramatic uptick post COVID of the amount of anxiousness, the amount of just not connecting the dots to get you to the right place.
Yeah. Yeah. It becomes our problem when it prevents them from doing the job properly.
That's it. And then, we sat in the '90s at some of these GEM conferences, and it's like, and it's like, hey, we didn't raise them, we weren't their father, we weren't their mothers, we didn't diddle them. It's not our problem.
Yeah.
But now in today's, in fact, that was probably not the right thought process back then.
Right.
But it is definitely not the right thought process now. Thinking drives behavior.
And providers say to me all the time, Kevin, when we're talking, is they'll say, I know this is not an excuse. I know I should leave this at the door, but I'd be lying to you if I didn't tell you that in the back of my head, this stuff was in my brain. So it's there. It happens. You can no longer say, leave your problems at the door. When you come into work, you got to forget the rest of your life and you just got to perform, right?
You can't.
Ideally, that would be wonderful, but that's just not reality.
No.
So if you, as a manager or as a CQI officer, have a little bit of that attitude in you, then you're doing a disservice to your providers. And this is not lovey-dovey, touchy-feely stuff. This is getting maximum effort out of your employees, but doing it in a compassionate and empathetic way. So you really have to deal with these issues whether you want to or not, and that makes it difficult. We did a podcast in season 1, Kevin, you might recall, which was The Therapist Will See You Now, and we talked a lot about the psychological component of being a CQI officer, and that a lot of times it feels like okay, if we're going to talk about this, lay on my couch, well, let's start the conversation, because it feels so far-fetched and far removed from EMS stuff, but it really is EMS stuff when it affects their ability to do the job, and it does.
Oh, absolutely. And I'll tell you, who I feel, and it could happen to any of us, but I feel horrible for Kayla Proctor. And Kayla Proctor was a 24-year-old nurse working in Georgia that was driving home after working three night shifts in a row. That went beyond the normal hours. Mm-hmm. On the way home, she purportedly fell asleep at the wheel and was involved in a crash that killed a 72-year-old woman. And, how that could happen to any of us. It could happen to us. And so that's a situation that I believe there was symptoms of this long before that crash, that CQI or, there had to be some type of evidence that this poor 24-year-old was suffering, taking on too much, putting herself at risk, putting the patients at risk, and obviously put a 72-year-old at risk while she was driving home.
Right.
Horrible situation.
Yeah. Yeah. So again, to get back is that a lot of personal stuff does come into the job, but non-personal stuff is also there. And again, another article that we wrote some time back, which is the 13 necessary elements for high quality care. We talk about patient care that goes wrong when you do a root cause analysis and you try to get to the why of what happened. It can come from a whole bunch of sources. We summarize them into 13 different sources, and some of those are improper dispatch, for example. So your BLS crew gets on scene, they neglect to call ALS when they should have. The QA process says, hey, how come you didn't call for ALS? And the BLS provider says, well, it didn't get dispatched, even though it's typically a dispatch call. I assume that's because they didn't have any ALS resources available. So you can fix the EMT a little bit with that, with, okay, make sure you ask and verify, right? If you need ALS, first of all, make sure that they understood that ALS was needed, right? That their assessment skills were appropriate, and that they understood that ALS was required on this call from a clinical standpoint. So that's one fix that you can put in. The second would be, don't assume anything from dispatch. If you think you need an ALS unit, call for an ALS unit. Let them determine whether an ALS unit is available or not. But then at some point, you got to go back and say, well, how come the ALS unit wasn't dispatched when it's part of their dispatch protocol to dispatch for an ALS unit, and go talk to dispatch, right? Go pull dispatch records.
Right.
So you really got to kind of get to more than just not yelling at the EMT for not calling the paramedics. It should go deeper to why didn't they call the paramedics, and then try to fix that problem.
Yeah. Hey, in your article, Understanding the Why, you talk about a medic that was skipping assessments. Can you walk us through that? And there was there was a positive change that happened there. There was a turning point.
Right. Yeah, this is a big one, and this happens all the time. It wasn't just that one provider, Kevin. This same scenario has happened numerous times over the last few years. And basically what was happening is this provider was not doing all of the assessment and or skills that he should for patients, which is not uncommon, right? That's bread and butter CQI stuff, constantly talking to people about more thorough assessments and better documentation of those assessments, and doing all the smaller treatment things that they should do and not cut corners. But in this case, this is a pretty solid provider, and we had 2 or 3 or 4 different discussions over a 3-month period or so where the discussion was, hey, how come you didn't ALS that guy? How come you didn't do a 12 lead on that guy? How come you didn't put CPAP on sooner for that guy? And normal CQI stuff. And the thought from a CQI officer standpoint is that you just got to correct this provider. It's his fault for not doing these things, and he should have done them. He should have seen that. But after a couple of discussions, I started thinking, hey, this is not you. You're usually very detail oriented. So it seems to me there's something else going on. What's going on? And at first he was a little reluctant to talk, but because we have a really good, solid relationship, and I've been working with this gentleman for years, he said, all right, Paul, here's what's going on, man. We've been working 24, 36-hour shifts for months now. I'm fried, and so are the other providers. We're talking amongst ourselves, the ALS providers, that we can't keep up with the call volume. I just can't keep up with 20 calls in a 24-hour shift. I can't do it. And he said, so what we're doing to preserve our sanity is we're basically getting them into the truck, getting them to the hospital as quickly as possible, cutting some corners to do that, right? Limiting on-scene times and whatnot, to dump them off so we can get to the next call, so we can get all these calls handled. And on the one hand, you have to respect and admire the fact that these dedicated providers are trying to get these calls at least done, getting the patients to the hospital, right? And they're hustling to get as many calls done as they can. The downside is all these patients were not getting served. So, and the key was, once he finally broke loose with that, then he was able to really discuss it in detail and get into it and talk about the stressors that they're feeling due to lack of staffing and burnout, and people were wanting to leave the agency just to go to a slower agency, not because they didn't like the agency. They just wanted to go somewhere where they weren't hustling all day long. They were trying to find the paramedic retirement home, right? Someplace that does 3 calls a week that you can do a lot of sleeping in between calls. And it was because they were just getting fried. So once we got to that why, instead of having a discussion of, hey, you should have done a 12 lead on that patient, and here's why clinically you should have done that, that whole conversation turned into the state of affairs of EMS, how everybody's dealing with staff shortages and overwork and underpay. Everybody's grappling with this stuff. But the take-home point is that you've got to take care of one patient at a time, and it's dispatch or management's job to right source the organization and to fix some of these complicated problems. You're not actually helping patients just by doing a rapid transport when they're not getting the care that they need. So it's creating risk for you as a provider that something bad's going to happen. You're going to get in trouble or jammed up or potentially lose your license. It's bad for the patient from a patient outcome standpoint. It's bad for the organization in the long term. So, but it also allowed me as a CQI officer to take that to management and say, hey, here's what's going on. And we're seeing it a lot amongst a lot of different providers, because I was also able to talk to other providers and kind of guide them into that discussion to get them to open up. So, management realized it. They were stressed and strained. To be honest, the stress on managers is as bad as it is on providers for this stuff. They don't have the answers either. But what did happen is it allowed everybody to speak openly, honestly, and frankly about the situation. They did try to make some changes and tweak stuff, and that made the providers feel like they were being listened to, and that management was actually at least trying, and that management was in the same boat as them to some degree, and not just blaming it on them. Hey, do more calls, hustle, and get this stuff done for us. So it had quite a ripple effect through the organization once we got to the real root cause of the issue, which was not a lazy provider or a provider that lacked knowledge or experience or skill. It was a provider and multiple providers in this agency that felt inundated and thought they were doing the right thing, when in reality they were probably creating more risk to the patient and to the service than what should have been.
Yes, that fatigue, sleep deprivation, nutrition,
right,
lack of exercise, all of that, no doubt comes into play when you're talking about peak performance. Can you imagine? Now we're out there doing the life-saving thing and working in really crappy conditions. We don't sleep, we don't eat right, we don't exercise, and some of that's our fault, but some of that is just the culture and the nature of the job. Right. Can you ever imagine? In order for us to do our job, I'd argue that we got to be in peak mental and physical performance akin to a professional athlete. Outside of the stories about partying, professional athletes, do you think for a minute that these guys are putting themselves through hell and then getting on a basketball court, football field, or baseball diamond, not being in peak physical condition, not getting that night's sleep, not putting the right nutrition and supplements into your body, staying away from the alcohol, staying away from the hooch? Did you see the story about the Pawtucket Fire Department?
No, not that one.
Yeah, Google that one. That's a good one.
All right.
Allegations. I don't frankly buy it, but I am a political conspiracy theorist when it comes to disciplining EMS providers without corroborated evidence. But anyway, but yeah, I mean, it is a nightmare situation for us in first response, and even these nurses. I mean, they're first responders too.
Right.
So in order to get away from that requires changing the CQI conversation. Yeah. Changing it from the what to the why. And most of these CQI reviews are structured around documentation, protocol, and performance. How do you shift that conversation to uncover the why?
Yeah, that's a great question. You really have to start with changing your frame of reference as a CQI officer. So what I personally do, because remember, we're human too, right? So you're the CQI officer. You just got told that your wife wants a divorce before you go into work the next day. Yeah. And then you have to have these discussions. For CQI professionals who are on the road and you work night shift, you're exhausted. So you say, well, I'm going to have a couple of cups of coffee, get my juices flowing, and then I'll meet with Kevin about his call. And, you get the caffeine jitters going, and you're kind of, rapid fire questioning at the person. So really, believe it or not, it starts with the prep work, the pre-meeting prep work. And you need to take a Zen moment. You need to take a moment, do the whole Om thing, calm yourself, get your mind into the right frame of reference to have this discussion, identify where you would like the discussion to go and how you want to frame your questions when you talk to the provider to get to why answers. So instead of the simplistic, why didn't you ALS that patient yesterday? And that's not really a true why question, even though it sounds like one. It's really, you're trying to figure out what went wrong. The reality is there are a lot of different questions that you can ask that will help guide them along that. One of those I mentioned to you earlier when I talked to that provider, where I said, hey, this is unlike you. You're very detail-oriented. You're on top of this stuff. This is not something usually we talk about. What's going on with you? I didn't ask anything that was obtrusive or too overly broad. It just it was an open-ended question that left it to that person to determine how much they wanted to share, what they wanted to share with me, and how much they wanted to share with me. And so asking some of those open-ended questions can be helpful. The other is, whenever I go into the meeting, after I've got my mind settled, is I walk in and I try not to start with the call. I try to start with a more personal, hey, how you doing today? What's going on today? How was your shift so far today? You guys crazy? Did you get lunch? It's 1:00. Did you get lunch already? because the answers to those questions tell me what kind of frame of reference they're in, and they open up the discussion points for other things to occur. So if the provider says, no, I haven't had lunch. Oh, you're really busy? No, I'm just dealing with other things. Oh, well, what's going on? And they're like, well, I was on the phone with my wife because we're having divorce discussions. I was on the phone with my wife because we're putting the dog down and she's at the vet right now and I can't be there. That impacts people. So one, the frame of reference of the provider of that particular discussion and how you might want to frame that. But it also gives you an opening to ask them some of those questions that will lead you to a why answer. Why they're doing what they did, or they're doing what they're doing. So that's before we've even really started the formal, hey, how come you didn't ALS this guy yesterday, Kevin, discussion, right? Yeah. So, and then once you get into that discussion, usually you have to guide that as well, because the natural inclination of the provider is to try to explain to you in clinical terms why they made their decision. So they're not giving you a lot of why answers necessarily, unless it truly is a lack of clinical knowledge or something that's directly EMS related that affected their care. But in most cases, there's not a lot of fertile ground there for the why issue. So you can still guide that discussion when they say, hey, how come you didn't do a temperature on this patient who's potentially septic? And they say, well, we never have probes. The probes that we use to get temperatures is always giving us faulty readings. Oh, how long has this been going on for? It's been going on for months. Oh, okay. Explain. Tell me why. What's going on? So, and then so you keep asking. It's almost like, and I equate this to, for anybody who's a parent, when you had 6-year-old kids and you're driving in the car and the kid's in the back seat and the kid says, why is the sky blue? Well, because, light filters through the clouds and there's a prism and blah. Why? Well, because, and they pester you, they drill down to the point where you get frustrated with them and you say, that's just the way God made it. You outrun your knowledge of answers. Yeah. To some degree, as a CQI coordinator, you want to have that probing, keep drilling deeper, but don't do it in a way that's going to make them feel like you're really trying to nail them to the wall. You're doing it in a way so that you can understand. So just keep asking that why question.
Yeah, I mean, you're being curious versus judgmental.
Bingo. Judgmental doesn't work. Curious
doesn't work anymore.
No.
It probably never. Well, I don't know.
Did.
Maybe it worked.
Nah, it didn't. It didn't. That's why.
I don't know. You're telling me leaving your paperwork where everybody, this is back in the 90s before HIPAA, leaving your paperwork on complicated calls where everybody who had a hell of a lot more experience than you, knowledge, skill, ability, proficiency, instructors, all of that, you're telling me that there isn't judgment for the new guy when you're trying to make it in that dog-eat-dog world?
There's a ton of judgment. The question was, does it benefit you? Does being judgmental, is that a good thing?
Well,
and to some degree, you could argue, if I were you, I'd argue that it was a good thing because it stimulated guys like us, right?
Motivated by fear.
That judgment. Yeah.
But fear of looking like an idiot.
Right.
Which you don't have anymore.
On some level. No, you don't have it anymore. In fact, that's gone completely away. Everything, when you do rounds now, people are doing the, hand-holding thing a lot more. Yep. So there's a lot less of the judgmental thing.
They still do M&M rounds?
Yeah. A lot of them electronic now. They're doing them by Zoom sessions.
And how does that touchy-feely stuff, do you think people are opening up about their feelings in M&M rounds?
Well, it's a double-edged sword. On the one hand, if you soften things up, people are not as afraid to admit problems if you know you're not going to get whacked for it, right? So I think there's some good there. Yeah. But I think it has taken a little bit of the edge off, right? That people don't feel like they need to be prepared as much. What I say to my coordinators when we're hiring them is you want to be kind and empathetic, but you still need to hold people's feet to the fire. That doesn't mean when they give you a bullshit answer that you just say, oh, okay, I'm sure you were trying really hard that day. You can't do that. You still have to hold people accountable, but you can do that in an empathetic way. You don't have to be overly judgmental to hold people accountable. So you still want to get to the driving point of we need this to change from X to Y because we think that's better in terms of patient outcomes and better for the patient and better for you from a risk management strategy. So there's a bunch of reasons that you need to hold people's feet to the fire, but you can do that in a kind fashion. And the problem is, I think most providers, and including medical directors, right, when they go to rounds and they're soft soaping everything, we've had medical directors, and you know who I'm talking about, Kevin, who, you know, we bring a CQI call to the medical director and say, that's terrible. That can't be allowed to happen. Go tell this person I do not want that happening. They need to do X, Y, Z, blah, blah, blah. Okay,
Yeah.
we go have that discussion with the provider, and the provider says, oh, I saw the medical director in the ER yesterday, and I brought it up to them, and he said everything was fine.
Yeah.
And you're like, and you
Yeah,
go back to him, and
absolutely.
you're like, what are you
Yeah.
doing? And he's like,
Look
well,
like a moron.
no, it wasn't that. Completely changes his thoughts on it because he didn't want to be the bad guy having the bad guy
right.
discussion.
Yeah.
So you could have tough discussions without being an asshole.
Right.
And that's what really you need to do as a CQI or as a medical director or as a chief of agency.
Yeah,
Right?
they
You
call
need to learn how to have those difficult discussions without firing people up about them.
Yeah, they call it having courageous conversations
Right.
that are authentic and
Right.
humanistic.
Right.
That's what it's all about.
Right.
And you know, it's realizing that it's not as important to be right as a CQI guy as it is to do the right thing.
Correct.
In my view, anyway.
And if you're wrong as a CQI guy, admit it. Just
Yeah.
fess up. You win so many more fans when the provider, you say something to the provider, they come back with a really good retort. You know, you're like, I didn't think of it that way.
Yeah.
But you got a point. And people will respect you and respect the process if they know that their opinions are being heard.
Yeah. Hey, one of the let's switch gears to coaching versus policing for EMS CQI. One of the most powerful parts of your article was, in my view anyway, reframing the CQI role as an advocate, not a disciplinarian.
Yeah.
What does that shift do to provider morale?
It increases it tremendously. And you'll see it almost immediately. Some of the most difficult people that I've dealt with who are argumentative, just people who, those burn down the building kind of folks, when you sit and you talk with them and they present things that they're right about and you give them credit for what they're right about, it almost always softens their stance.
Yeah.
They become, over time, it takes a little while, but if you consistently are that way and you become their advocate, if they did something right and you need to go back to the medical director and say, you know what, I agree with the provider on this one, Mr. Medical Director or Ms. Medical Director, here's why. And you list your clinical thought process behind why you agree with them and you stand up for them. Even if you lose the battle and that provider still, medical director still all over them a little bit, they will actually respect the fact that you stood up for them. CQI is not the internal affairs division of the organization. It is not there to find fault and culpability and to reprimand people. It's there to help people get better. So if you did something good, you should be applauded for it. We have in our system, we have a kudos checkbox when people do something good. In our scoring system, we have what's called a category 4, which is the highest level. It's called a high risk of an adverse patient outcome level, right? So it's the highest risk problem that we find.
Yep.
And a provider can get a category 4 and a kudos on the same call. And that messes people up. Auditors will call me and say, hey, I just made this a 4 because they didn't defibrillate this VFib for 6 minutes after they got to the patient's side for no apparent reason. So that's a 4. And they say, but he also did a great job on the airway. But I feel funny giving him the kudos. And I say, no, give them both. Put them in there because when it goes to the coordinator, and in our system, our coordinators and our auditors are 2 separate roles, and we do that intentionally. When it goes to the coordinator has some good stuff to work with here. You want to have the discussion about the VFib needing to be defibrillated early, but you also want to tell that person they did an outstanding job on the airway. Now we just got to blend those two together so that it's better for the patient the next time. So stand up, become an advocate for the provider when they need an advocate. And they will appreciate you for it, and it will gain credibility and respect for the CQI department overall, which will make your job a hell of a lot easier.
All about building that relationship.
Correct.
And
It's all about the
that
relationship.
Trust. Yep. All right. System fix versus provider fix. In the story, the real issue wasn't the provider, was it? It was the system.
No.
Can you talk about how recognizing system stress changes the fix?
Yeah, again, it takes that pressure off the provider. So the easy thing would have been to go back to the provider and say, hey, you're taking shortcuts on all these calls. Stop it. Bad paramedic. You're not ALS and people who need ALS. You're not doing good thorough assessments. And it would be easy just to pin all the blame on the provider. But the reality is there were system issues going on here, and that's not uncommon. in EMS, because EMS is a complex environment. So you really, on every call, should be looking for the why, but beyond simply the provider's portion of it. So you got to fix the issues that pertain to the provider, but you should also be always looking for, is there something else within the system that needs to be addressed, and have that discussion with the provider as well, right? So when they say, hey, listen, I can't do, PD blood pressures because there's never a PD blood pressure cuff on the unit. It's always missing. You can yell at him for not doing his checklist in the morning, right? And that's how most coordinators would do it. Well, you would have found that if you did check. But if there's why are there never be PDBP cuffs on the ambulance? What's going on there, and how do we fix that? That becomes the issue. And now the provider can, if they need to take the hit, they'll take the hit if they know that you're also fixing all the other stuff. If they feel like they're the sacrificial lamb for the system's problems, that's when there's pushback, and that's when there's resentment. Even if they don't push back, they're going to resent it. And that's why people fear and hide from the CQI process instead of welcoming it with open arms as something that's going to help them be a better provider.
Yeah, it's the inter-office politics. It's the lack of trust. It's you see one person treated differently than the other for the same offense level, that type of thing. And that never works. It never works. So that's what you mean by systems level root cause, right? How often and how often does the systems level root cause drive the provider problem?
That's a good question. That's a hard one to answer because every agency is a little different. So you have some agencies where they have really competent management that really dots the I's and crosses the T's on everything, right? Everything is black and white per regulation type of stuff. And those systems, generally, there's less systems issues because they're kind of on top of it. I couldn't even venture. I would say that for most agencies, between 30 and 50% of your issues, if you drill down far enough, are probably somewhere systems issues. Now, remember, it's not just system being your service. It could be your medical direction, not providing good leadership as medical direction. It could be the training institutions that you hire from do a poor job of teaching certain topics. It can be your orientation process being faulty. It could be dispatch being faulty. It could be there's all sorts of stuff, equipment maintenance issues. So there's all sorts of things that could be the root cause. And 95% of these cases, CQI officers are basically laying it at the feet of the provider, when really only 50 or so % of the cases is really the provider's issue. And again, these are just numbers I'm kind of throwing out there randomly. I don't have a number because it varies so widely between agencies. But I would say that if you're a CQI professional, always look for the system issue that underlies the clinical issue from the provider.
And the great news, my friend, is Just Culture is on its way in EMS. And that will be a driving force into looking at these system issues that impact provider performance.
Right.
All right. We've said from day one, from our first podcast, that we believe that the EMS CQI area is the most important function in an EMS agency. And that we've maintained from the get-go that we're change agents. Mm-hmm. You said in the article you are their advocate. How can EMS CQI leaders use their position to help the staff feel heard at the leadership level and drive meaningful change? You know what I'm saying?
Again, that's a good question, is that if you can build your reputation as a CQI officer as the bridge between staff and upper management, and that you realize that's a bi-directional role, then again, you will gain immediate credibility with the field providers, and management will also respect you as well if they know that you're the bridge that goes between. You're going to bring them what the providers are saying is really going on out there so they can enact good stuff. And then you can take messages from management and explain not just what management wants you to do, but why they want you to do it, right? Another why issue here. So a lot of times people don't do what the new protocol says or medical direction says or management says because they don't agree with the policy. They don't agree with the memo, right? That doesn't make sense to me. I can't believe you want me to do that. And a lot of the discussions I have with providers when we're talking about why they have to adhere to certain parts of the protocol is I'll say to them, well, when you sit in on the medical services meetings, or you sit on the regional meetings, or you sit on the various meetings where the protocols are being developed, or when you talk to medical direction, here's what they're trying to solve. Here was the issue. And you put that in context for them, then they kind of understand why you're asking them to do additional stuff that they don't think is necessary, for example. So a lot of times, if you can explain to them the why of management, then that helps them to understand what they really are trying to get at when they're trying to enact some of this stuff. But it also allows you to get feedback from the provider and say, well, I still think it's kind of stupid, and here's why. You can then bring back to management and say, well, here's some holes in your policy, right? So here's some of the things that people are bringing up. That's an issue that makes this policy enactment complicated. So, doing the why thing on the management level is as important as doing it on the field level. And if you can be that person who has that why answer going between the two and explaining to two, you're the interpreter between two different languages that you can help to bridge that communications gap. So it's a big way for you to change your role in the organization because you become a much bigger influencer if you do that than if you just go tell paramedics that they should have ALS that guy yesterday.
Yeah. So what's the impact in your experience? What are you seeing when paramedics feel like CQI is actually on their side and not the compliance department or not the Gestapo?
The pace of improvement accelerates exponentially. People actually will make changes to their practices much more if they feel heard and they feel like you're getting to the root cause of things, that you're their advocate. All these things we discussed today, providers respond well to in most cases. And so they're more willing to listen to you and to make changes when you bring those changes to them. But the other thing you're going to see is that the things that used to get swept under the rug, or people would try to, let's not bring it up and maybe nobody will notice type of stuff, they bring up. And so you're able to find problems that you weren't finding before that you can then fix instead of waiting for people to repeat those same behaviors until something bad happens. So you have a greater degree of confidence that the care, that the improvement that you're aiming for is actually happening because you feel like people are being straight, direct, and honest with you. And if there's an issue, people are going to let you know out there that there's an issue. So it accelerates the pace of change. It accelerates the improvement process. It makes that organization better, tighter, faster. So if you want to tighten things up and be a better EMS agency and make sure your patient care is top notch, speed up the QA process.
And that's not just braggadocio. That's supported by the GNA database data. Is that right?
Yeah, that's correct. That's what we see all the time. We see that agencies that are slow to improve will often identify a lot of these contributing factors. And then and it takes time, right? This takes months, if not years, to do this.
Right.
This is not
changing a culture.
Yeah, exactly. Yeah. So it takes a while, but you can, we've had some agencies we've been with for 17, 18 years. And when you look at what they were doing 17 years ago in terms of patient care quality and their scoring using our scoring system, and you look at what they're doing today, you can see this huge difference. We've had time to change the culture. We've had time to get people to understand differently. Even the management will hire different employees based on that change in culture. So they'll be looking for a higher quality employee that matches that new culture that you have. And that helps too, because you're not hiring people that are coming in and bringing bad stuff with them and they're changing the culture to a negative degree. So the benefits are huge and go much deeper than just simply whether patients are getting better treated. It's a better organization, a better organizational culture. People enjoy their jobs more. It fixes a lot of those things that are intangible that management has a hard time fixing on a one at a time, see if we can't fix morale today kind of thing.
All right. Let's boil this down. For CQI's, for our CQI audience listening today, what are 3 things that they can do tomorrow to better understand the why?
I think one is to change their approach to the discussions they have with individuals. And that approach should start with understanding the totality of why they did what they did on that particular call and inculcate that into your approach, right? Mm-hmm. So you should approach these people with a less of a blame type of an attitude and more of a, I just want to understand. Just help me understand why this happened the way it happened. So that's one. The other is building it into your culture, getting management on board. So management also tries to build that trust with the staff level folks. That's a challenge and that takes time, but that would help tremendously. But Getting everybody on board is critical to the whole dynamic working properly. So I think those are, a couple of things that you can do to start changing the culture, but be open-minded, right? Listen to what they're saying. And in spite of the fact that they're doing it different than how you would do it or how you're trying to advise them to do it, listen actively about what they're saying and question whether your approach is the right approach, right? So sometimes the answer is not my approach versus yours. Sometimes you got to merge the two approaches and say, all right, let's do a little of what you're saying and a little of what I'm saying, and that's probably the best place to be at. So again, be non-judgmental, change your approach to how you deal with people, get management on board to the degree you can. If not, start from the bottom, get people on board trusting you as the coordinator, and then you have more clout to go to management and get them to change their behaviors when you have the staff behind you saying what your coordinator is saying is true. This is what we need for bettering patient care.
That's gold, man. That is gold. Look beyond compliance. Ask what's getting in the way of excellence.
Right.
What's getting in the way of being an EMS 1%er. Yeah, no, I mean, that's gold. The EMS, in my view, the EMS med mal lawsuit or paramedic license revocation hearing that you always win is the EMS medical malpractice or EMS provider license revocation hearing that you are never in. Take salvation in your EMS CQI program. Any final thoughts, Paul?
Just that there are a lot of these things that we discussed, podcasts about the therapist will see you now, 13 elements for high quality care. Some of these things that are contributors to what we're talking to Getting to Why are all on our website. So feel free to go to the website, check those articles out, check out some of those other podcasts that we've done in previous seasons. And they're still relevant today, even though they're older. But be open-minded, stay in the fight, and keep fighting the good battle to improve patient care.
All right. And that wraps up this episode of the G&A Way EMS CQI podcast. We hope you gain valuable insights into the importance of understanding the why in EMS CQI and how that deeper insight can truly elevate the care we provide to our patients and keep us safe as well. Visit our website at www.gerardassociates.com for more articles, tools, and consulting support. Be sure to subscribe on Podbean, Apple Podcasts, and YouTube so you never miss an episode. Join us on LinkedIn. Please join us in the dialogue. Leave comments. For Paul Gerard, I'm Kevin Kelly. Stay safe, stay tuned in, stay engaged, and let's keep striving for a safer EMS experience for our patients and providers. Have a great day.
See you soon, everyone.
On 5.